The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk.
Hello, everyone. Welcome back to another episode of the Success in Practice podcast. I'm joined today by Phil Austin. Since graduating as an osteopath in 1997, Phil has gone on to complete a master's and a doctorate in pain medicine. He's worked as an osteopath and research fellow in the field of chronic pain and cancer pain in palliative care. This has allowed him to combine a broad range of osteopathic techniques and current evidence from various fields of work to give a more integrated approach to healthcare. As such, his passion lies in personalized treatment that focuses on manual therapy, exercise prescription, and psychosocial education. I'm especially interested in the relationship between mood and sleep myself, and this is somewhere that Phil is also has an interest in. So I'd like to discuss that with him as well, and also on the severity and persistence of musculoskeletal and abdominal pain. He's also a visiting fellow on the palliative care clinical studies collaborative at University of Technology in Sydney, a module leader for the master's program in clinical management of pain at the University of Sydney, and he is the author of the book Chronic Pain, a resource for effective manual therapy. Phil, thank you for joining me today, mate. I'm grateful that we finally had a chance to do this.
A pleasure.
I got to talking to Phil, and that's probably the first time we met on the sidelines of the recent Osteopathy conference in Sydney, and we had a good old yarn. And I was particularly interested in that conversation because there were some things that we talked about that we kind of agreed on. There were some things that we didn't agree on. So I'm especially interested tonight because I'd like to kind of continue that conversation, and I think the listeners will be interested in that. But before we get on to that, Phil, mate, I want to know a little bit about you, where you grew up. Tell us about your background, your childhood, your high school years, what made Phil kind of tick the way he ticks today. Tell us how you kind of finished up your schooling and got into osteopathy. Start us at the beginning.
I grew up in the northeast of England in a university town that was surrounded by coal mines. And my life was sort of, pretty ordinary. Grew up on a housing estate. Did what boys do. I left school really early. I left school just after I turned 16, and I went to work as an apprentice as a sign maker and fabricator, and I did that for a couple of years.
Which football team did you support, mate?
Newcastle United, of course.
Right, okay. And when we talk football, it's the global game, the real football.
Yeah,
a lot of the Melbourneites that listen in Australia think that AFL.
I still go home twice a year to watch games. So
right. Anyway, continue on.
Yeah. So there was no real prospects in the area. I mean, even though I had a job, the unemployment rate was like nearly 25%. Factories were closing down left, right, and centre. So I decided to bin it on a whim. I was walking back from my hometown back home, and I didn't have enough money for a bus fare, and I took shelter in a Army careers office because it was raining, and the next thing I knew, I'd signed up, which in retrospect was probably the best thing I ever did.
For the Army? You signed up for the Army? Right.
So I did 9 really good years in the Army, really enjoyed myself, got the most out of it. Did a lot of sport, represented the Army in cycling, did a lot of rock climbing, adventure training, and got paid basically to have a good laugh.
Great. What year was that, Phil? What year was that?
So I joined in 1984 and I left in 1993.
Right. And that was, I mean, there wasn't major conflicts there that you would have got into.
There was no conflicts when I was in the Army, so that's why, that's why I had a great time.
That was just after the Falklands War.
Yeah, so I joined, the Falklands was a bit of an inspiration.
Yeah.
And then just as I was leaving, the first Gulf Desert Storm kicked off.
Yeah.
But I was working in a training depot, so we were training people to go out. And at that point, I was looking to not do my full time, but I went back to college in the meantime, which the army paid for, and I got myself my HSC equivalent. And during that time, I applied to do physio, but there were so many people going for physio that there wasn't a hope in hell. And I got injured in a bike race, and my boss in the army said, "Go see this guy. He was an osteopath." And he's like, "Why don't you do this?" I'm like, "Oh, I'll have a look into that." And I managed to scrape together a scholarship from my local county council, and I think I was the last person in the UK to get it. So I thought it was destiny. And I started at the European School of Osteopathy literally a week after I left the army. Well, 2 days after I left the army. I left on the Friday and I started on Monday.
And that was, I'm assuming, probably late 80s, 88, 87?
No, that was 93 I got out. So
93,
93, yeah.
Yeah, okay. All right. And then, right, so we've kind of had a chat about your early years, and so you get into osteopathy at the European School of Osteopathy.
Yeah.
And did you have an idea of what was going on, or were you just...
Yeah, I mean, I'd done my homework beforehand, and I took and I did a lot of sports injuries type stuff in the army. I did a lot of taping courses for injuries and a lot of life sciences as part of the job as a physical training instructor in the army. So I had a fair idea, and I just like the whole concept of osteopathy with structure and function. That sort of really appealed to me at the time.
Yeah, right. And okay, so what was that like? Tell us about. I know you like the structure and function aspect, but your actual osteopathic education. What was that like? Like, tell us about that.
It was pretty diverse. I mean, I think the European school's got quite a sort of airy-fairy reputation for a lot of cranial and a lot of sort of BLT type stuff. I tried my very best to get into it, but I couldn't get my head around it. It didn't make sense to me, so I sort of I stuck with the more structural techniques.
And was that available to you in a good enough quality at the European school that you were able to kind of...
Oh yeah.
And so
we had some really good lecturers who were sort of from the BSO as well, who were sort of renowned for their more structural approach. And actually, the guy who I went to see after that bike crash, I knew he worked at what was called the BCNO at the time, the British College of Naturopathy and Osteopathy. A guy called Devan Rajendran. And when I was coming into my fourth year, he rocked up as a tutor, and he looked at me, and I looked at him as like, and he's like, "You did it." I'm like, "Yeah, I did it."
It's like, "I was joking. What are you doing?"
Yeah. So we've been like the best of mates ever since. So.
Oh, that's good. That's a good story. Yeah, right. Okay. And so you graduated, and what was the mindset at that point? I mean, I'm going to ask you about your early career. Yeah, like, I'm going to ask you about...
I was still fairly open to the cranial stuff. I mean, I was still trying to get my head around it. But I always kept going back to stuff that made sense in my head.
Right. And
logical stuff.
Yeah. Okay. Well, I mean, it's hard to have a background in the army and be regimented and follow orders and understand the process of A, B, C, D, E, and then have a more of a fluid approach to kind of opening up your, I guess, your mind to something like cranial or the indirect stuff. But in terms of a mindset of going out there as a young practitioner, I mean,
I was 31 when I graduated.
I get it, but young. Well, you weren't young, but you were let's call you an early career practitioner. You just finished university. You're now going to be responsible for looking after patients. Was that daunting in any way? Did you kind of just take that in your stride? Did you feel you were well equipped?
I just took it all in my stride. I mean, I think because I'd come from an army background, I just thought I was invincible. I just thought, I get knocked down, I get up again. If I make a mistake, I'll make sure I don't make it a second time, sort of thing. So I just sort of cracked on, really. And I moved. And I got a job in New Zealand, so I was straight over there with no real time to think about what I was doing. And I got this job in New Zealand, and I landed on my feet there. Really, it was a fantastic place to work.
Has that stuck with you? That type of mindset where you just kind of,
yeah, absolutely.
Things? Yeah, right.
Should be if it changed.
Okay. All right. So you went to New Zealand. You just mentioned you went to New Zealand for your first job
Yeah.
post graduation.
Yeah.
And so what was that? Was there a different type of I guess approach in New Zealand as opposed to what you learned in
No,
Europe?
not really. I mean, the girl who took me on, she was 2 years ahead of me, the ESO.
Mm.
I knew a lot of people out there, and an even stranger story. I mean, literally an hour after I'd landed, I bumped to an old army mate I hadn't seen for like 10 years. Just happened to be sitting in the same cafe as me, so it was like an instant social life.
Yeah.
And it was, yeah, the osteopathy was great. The social life was great.
Yeah.
Yeah.
Yeah, right. And tell us about osteopathy in New Zealand at the time. Was it registered? Was it
Yeah,
recognized?
it was
Was it?
registered under the MNZRO.
Yeah.
You have your ACC stuff there, so a lot of people came in on this accident. I can't remember what it stands for, but so it was more available in New Zealand than any other country I've been in, to be honest.
Mm.
And it still is, because I do a bit of sort of side work there now. And it was just normal. There was quite a few clinics knocking around. There was probably, I can't remember how many osteopaths. I'm going to stick my neck out and say about 400 osteopaths in New Zealand.
Mm.
There was a great sort of peer group sort of social life as well. And at that time when I first moved there, that a new college started, a new course started, the first in New Zealand, and it was set up by a guy called David Patriquin, who was an American DO whose mother was taught by Still. And I sort of made a beeline for him as a mentor, and he was quite happy to take me on because I was more enthusiastic than everyone else. And I learned a load from him.
Yeah, right.
And he sort of pointed me in the right direction for sort of different approaches and what have you. And he gave me some sort of sense into it all. So that the cranial approach, he gave me another viewpoint on cranial. The sort of balanced ligamentous tension type stuff, which made a lot more sense to me at that time.
Yeah. Okay. All right. And so and it was fairly busy time for you in New Zealand?
Yeah. And I was doing all the hobbies I wanted to do. I was, I didn't have any kids at the time. Loads of
And
travel.
were you married at the time? Were you?
Yeah, I'd been married. I was married to my first wife at the time.
Right.
And she got really homesick, so we ended up going back to the UK after 2 years. Yeah.
All right. So I guess it sounds like you had a great experience in New Zealand.
Absolutely.
And then he packed up 2 years later, went back to the UK.
Yeah.
And you hadn't practiced in the UK yet.
No, just a student.
Right.
I'd done a couple of weeks cover before I left.
Okay. And so, what was the registration process for you like going back to the UK? Was that easy?
Well,
was that difficult?
It wasn't difficult. It was a pain in the bum because when I was away, they revalidated. So it went from the MRO to the General Osteopathic Council. And everyone who'd been graduated more than 2 years had to revalidate. So it meant a whole load of sort of portfolio stuff, which I had to do. And it was a bit of a pain to get it all sent over from England to New Zealand and get it assessed back in England. And it was quite expensive, especially with the dollar being, the NZ dollar being so weak at the time. And I was still trying to pay back my student loans and what have you as well. Even though I got a scholarship, I still, and I was running a couple of jobs at the same time. Your debt's still mounted up, doesn't it? So
yeah, all right.
But we did it. I mean, there was a couple of us English guys who knew we were going to be going back at some point. So a lot of the Brits out there didn't bother because they said they were never going to go back again. But we made the effort, and I'm glad I did because I literally, a week after I got back, I started work.
Yeah. Okay. And easy to get a job over in the UK once you got back?
Yeah. Well, I mean, because I knew a lot of the lecturers and stuff, and I got on well with them, and I was a mature student, it sort of helped me a little bit. And as soon as I got back, I got offered an associate job.
Okay. And what was did you find differences between working in the UK and working in New Zealand?
Not really. I mean, different practices are different. I mean, the practice in New Zealand, I only worked in one practice in New Zealand, and that was, you could do what you wanted, really.
Yeah. How would you matured as a practitioner at that time, and were you practicing any differently?
I don't think I was practicing differently. I think I just had a deeper understanding of why and what I was doing, to be honest. I mean, I think there may have been subtle changes in my techniques, but I don't think anything major.
Yeah.
I mean, over the whole time I've been practicing, there's been no major changes in direction, to be honest.
Right. So what you're saying is there's not much new under the sun in terms of
From the hands-on stuff, not really, but I
Yeah.
mean, the chit-chat, my conversations with patients have changed dramatically, of course. But
Yeah. Right. But what goes on in your mind, your thought process, how you construct things, how you put things together, that's largely something that you have, that hasn't changed a lot. Might tweak it a little
not
bit.
for osteopathic technique, no.
Yeah, right. Okay. Well, that's been the common feedback from most of the people that I've had a chat to on the podcast is that they're not really, although they might learn new techniques on you, but in terms of their thought process, there's not much that changes once they get their flow right.
You do what you're good at. I mean, I think it's pretty
You
sort
play
of
your
elementary.
strengths. Yeah. All right. So how long were you in the UK for at that time?
I was in the UK for 6 years.
Yeah.
And at that time, I went back and taught it. I went back as a clinic tutor, and I taught visceral osteopathy and
Was that
applied anatomy and a couple
is
of other
that the
things.
BSO at the European School of
Yes,
Osteopathy?
yeah, European school.
Right. And you taught visceral osteopathy,
Yeah.
and you kept practicing at that time. 6
Yeah,
years
yeah.
goes past. You make the move to Sweden. Is that correct?
Yeah, so we moved to Sweden. I mean, in that time, I got divorced and met someone else who was also an osteopath, and she wanted to come to Oz sooner, but my mother was terminally ill, so I said I didn't want to leave Europe until she went. And I mean, she went after 2 years, but we stayed there for another 6 years. We had a great little practice, multidisciplinary practice. We had Pilates. We had a guy who was a psychotherapist, a couple of osteopaths. Some old ESO people were there. So, and it was, and there was and we weren't regulated. So it was like, we were like sort of pioneers.
Yeah. How interesting is that to you? Like, it's like the Wild West, right?
Refreshing. I mean, you couldn't get any treatments on insurance. And it was so, and there was chiros who were regulated over there, and there was things called naprapaths that are only in Sweden and Norway. And I took it upon myself with the help of GEOSC in UK to try to go for regulation of osteopaths in Sweden. And we got as far as a government meeting, and they were like, great presentation, but we got so many manual therapists, we don't need you. And they were really blunt and honest and friendly, and I sort of get, okay, I'll just stick to my job.
Fair enough.
And I was doing lots of sort of teaching as well for ESO around Europe at the time as well, so I was plenty busy.
And are they regulated now in Sweden? Has that changed?
I think they're still trying to get it. I mean, we're talking imminent or not. I'm not sure.
Right. Okay. So you weren't regulated in Sweden.
No.
I want you to compare the practice that you're in Sweden versus the practice either you're in right now or you were in the UK. Do you think there's much difference in terms of what you could do or what you couldn't do?
No, I mean, in Sweden you could get away with anything. I mean, literally, if you went to a quack as a patient, us being quacks, and you got hurt, it was your own fault for going, unless there was intent from the practitioner to hurt.
Right.
So it was, but my practice still was basically the same. I mean, I didn't change.
Okay, I don't really. It's not like I'm taking a position on this, but
I can't hear you very well. We're going in and out here.
Sorry,
I don't know if it's my end or your end.
I can hear you very well. Can you hear me?
You come back in again now.
Yeah. Right. Can you hear me now? That's all good?
That's all good.
Right. Okay. So what I wanted to ask you is that, like I said, I don't have not that I'm taking a position on this or I'm trying to get something out of you, but you've worked in a regulated environment. You've worked in an unregulated environment. And you said that there's not much difference in terms of what you could do and no difference at all, really. What do you think?
You do what you. I mean, there's an element of safety that you have to adhere to, and it really doesn't matter if you're regulated or not regulated. You still got to adhere to that safety aspect. So
of course,
you're still working within the confines of what you're being taught.
What do you think is the benefit of regulation then?
Oh, good question. for me personally, none whatsoever. Apart from maybe, regulation has never really helped me as a practitioner. It hasn't done me any favors, if you like.
Right. So at the moment, you're at St. Luke's. Is that a hospital? St. Luke's Hospital?
Yeah, it's a private hospital in
It's a
Potts
private
Point.
hospital and in Potts Point in Sydney. And you work in the palliative care section there, looking at
No, that's a different thing. I work in Greenwich Hospital for that.
Right. Okay. Sorry. So at that St. Luke's, you're there as an osteopath and you're treating chronic pain patients. Is that correct?
No, it's just a normal osteopath practice. It's got
Just a
nothing
normal
to do
osteopathic
with
practice.
Yeah,
Right.
yeah.
Do you think
the research and the clinic stuff separate?
Okay. Right. And so, do you think that that's afforded you regulation has afforded you the ability to be in a hospital setting?
Yeah. So I have to be a regulated osteopath,
right,
to work. You have to be to work in Australia anyway. So it doesn't matter where you work. You still have to be regulated.
Yeah. But I mean, like, massage therapists or myotherapists, they're not regulated, and I guess they wouldn't have a foot in the door in that.
I think they might. I don't know. Here's a bit of a weird place because I'm the only sort of, there's a podiatrist here, but the rest are like plastic surgeons, hand surgeons, orthopedic surgeons, and IVF. So I'm a bit of an outlier here.
Okay, right. And I guess there's access to government funding as well in terms of regulation. That would help with access to Medicare and things like that, which you wouldn't get otherwise.
Yeah.
Right. Okay. So this is interesting because we've talked about coming to the UK, and then you did your 6 years in the UK, and then you went to Sweden. How many years were you in Sweden for?
7.
7 years in Sweden, and that's where you met your second wife, or you spent time there with your second wife, and she was an osteopath as well. And then after 7 years, you decided we're going to Australia.
Well, I got a job offer as a researcher with a guy called Phil Siddle, who at the time was like quite an eminent pain guy across worldwide.
Okay.
And he started the pain masters at Sydney with a guy called Michael Cousins, who you probably heard of. And they took it to Edinburgh, where I did the pain masters. And I used to attend the International Association for the Study of Pain conferences, and I met all the Aussies at the conferences, and we talked during during drinks and stuff that, my wife had an Australian father and all that, and they're like, if you ever move to Australia, give us a buzz. So that's what I did.
Was that the job offer? If you ever move to Australia, give us a buzz.
Yeah, we'll set you up with some research.
Yeah, lovely. All right. So you decide to pack your bags and go to Australia. You're not coming to a private practice here. You're coming to a research position. Is that correct?
No, that was only 2 days a week. Yeah. So I still had to do my mentorship. So basically, I had to do, at the time, as a British osteopath, I had to do a 3-hour theory exam. I had to do up to 6 months mentorship, and that was with Heath.
Clarification: that's none other than the famous Heath Williams.
And the other funny story with Heath at that time is when I lived in Sweden, he recommended his brother-in-law, who was living in Sweden, to come see me because I was the only osteopath who had a recognised qualification.
Mate, Heath he's like he just sets everybody up together. The guy's he's a social beast.
Brilliant.
Yeah.
So, and then he just turned, by chance, he was my mentor.
Yeah, right. Well, he's a good guy, Heath, and he's a good mentor to have. He's knows his stuff and is also a gentleman, and that's
massively.
Yeah, right. Okay, so you did your mentorship with Heath, and
then we had to do a full day of clinical exams down in Melbourne.
Yep.
And it cost, it was a good 8 to 10 grand by the time we'd finished to get set up. And I got there, and I had the examiner come in, and I started explaining what I found and what I was doing. They're like, "Oh no, you don't have to do that. We're just observing you."
Yeah, right.
And I said, "No. I spent all this money and all this revision. I'm bloody telling you what I'm doing and why." He's like,
how did you find that process, Phil? The examining, the assessments, Was it something that was kind of like, did you have to work hard at it, or was it within your reach?
Yeah, well, I mean, I wanted to do well because I'd been in practice for a long time and I didn't want to look like an idiot. I mean, that's what drove me to do well. And I did do pretty well. But that doesn't work anymore. There's a reciprocal agreement now between Australia, New Zealand, and Great Britain. So
yeah, right. Okay. So well, so then you arrive here. You did your mentorship with Heath. Where did you work to start? I mean, you had 2 days. Where did you
I
work?
worked in the city, and I tried to start my own practice.
Which city are we talking about, Phil?
Sydney. Sorry, Sydney.
That's right. Who did you work with?
Place, and it was a complete disaster. I couldn't get any traction at all.
Right. Where was that? Sorry, which
it was CBD
clinic.
Yeah.
Yeah.
But it was just GPs and a physio.
Right. So it's not like you found an osteopath said, "Hey,
No.
right." Okay, and
so
you
I
couldn't get
there.
Yeah.
And I lasted about a year, and then Elevate Clinic had an osteopath.
Sorry to stop you there for a second. What you see? You didn't get any traction. What were the problems there? Do you think?
Just no referrals. Couldn't get my name out there. I tried.
What year was this, Phil? What year was this? What year were you talking about? Yeah.
It was 2014.
Right. So
I had twins at that time as well, and I was like all over the place.
And had you thought about doing any marketing work, any kind of advertising?
Yeah. I set up my website. I did everything myself. And I mean, it was just bits and bobs. And then there was a job offer at a big multidisciplinary clinic in the town, and I grabbed it.
Okay.
And that went really well.
Were there other osteopaths there?
No, I was the only one. There was a chiro, there was loads of physios, there was GPs, there was all sorts of people, psychologists, and that was a great opening for me.
Yeah, right. Okay. And how long were you there for?
I was there till 2018, and at that point, we had this like luxurious clinic in the middle of Sydney, and the woman who took over as the CEO bled it dry to the sum of 21 million in debt, and it shut down.
Yeah, right.
And that's when I came here.
Right, and so from there you moved over to Potts Point to St Luke's.
Yeah.
And you've been there since, and that's your own show. You're running your own show.
Yeah, it's my own show. I lease the room.
Right.
How
have you found traction there?
Yeah, fine. I mean, I had to start again because a lot of the city patients didn't want to come out. It's only one suburb over from the city, but during the day there's only one train every 10 minutes, so your lunchtime's buggered if you miss your train, sort of thing.
Yeah.
So I started again, and the patients in Potts Point are unique, shall I say? It's a pretty amazing area. The whole cross thing is. I love the cross vibe.
Yeah, it's you're probably lucky that you're there now, not like in the late 90s.
I wish I was there for a little bit in the late 90s just to see what it was like.
Yeah. No, it was definitely a vibrant and colourful place, put it that way. Yeah. So tell us about your current role now as an osteopath, as a clinician. What is it that you're interested in? What is it that you're seeing? And where do you like to take your practice?
Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you, and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also, in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
As again, nothing has changed much. The only thing I'll say is that my conversations have changed because of the research I've done, and a lot of the advice I give is based on what I've worked on in research and what I've read in research. Yeah. So, for the chronic pain, I was the research arm for a chronic pain program at Greenwich Hospital, and that was based on meaning and purpose and finding hope and gratitude and things like that sewn into, the group process. And I found that really fascinating. If you give someone meaning, it gives them a reason to get up in the morning, and it gives them a reason to do their exercises, and it gives them a meaning, to move forward. So I do talk a lot about that, finding hope, embracing hope, relationships with others. And it's, I'm not going to say it's psychology. Well, I suppose it is psychology, but I'm not a trained psychologist, so I can't really comment, but it's what I've picked up along the way.
Yeah.
And
right. And so do you, being obviously into chronic pain, do you attract people that have, or
that's what I wanted to do, but no, it hasn't turned. It's just a bog standard practice. I mean, I get the occasional patient who's seen me on some research thing, and they've contacted me, but I would say 90% of my patients are just bog standard osteopath patients.
So just general population.
And I quite like it that way, to be honest.
Definitely.
It's what I know. I'm not trying to reinvent the wheel or nothing like that. I'm just trying to, fine tune and tweak stuff.
Yeah, right. Okay, well, let's talk about your role in academia, I guess, and tell us what you're doing there at the moment. Like, what's been your history there? What are you doing at the moment?
Yeah, so my osteopath academics now has been finished for years, so I'm not doing any of that anymore. But here, I've got the role on the Sydney Pain Masters, and I was doing something similar on the Edinburgh Pain Masters. It's exactly the same course, and I run the visceral pain module. So it's just a case of I run a discussion module twice a year, and I set them essays, and I mark those a couple of times a year. And that's basically my role at Sydney Uni. UTS is a bit different. It's a collaborative of researchers and looking at different symptoms. So I'm in the pain symptom node. There are fatigue symptom nodes. There are cognitive deficit symptom nodes. There's all sorts of stuff, but I'm in the pain one. And basically, we've been looking at virtual reality, how virtual reality reduces cancer pain in people receiving palliative care. I'm currently revalidating a questionnaire we developed years ago that determines whether pain's being driven from the brain down or from the periphery up, and it helps sort of siphon management more quickly in pain management sort of settings, if you like. So we're going through a sort of focus group and cognitive interview process next year to see which questions in that questionnaire are relevant to palliative care in advanced cancer pain.
Yeah.
And I'm only down to half a day a week on the research now because of the new rule and contract laws that Albanese brought in last year. So I'm not allowed to work on a rollover contract, which I had to do for 10 years because I was grant funded. Yeah, and I wrote my own grant applications every year to get funding for the following year.
Okay. All right. Well, I guess working in that side of, I guess, pain, I don't want to call it pain medicine, or understanding pain, really.
Yeah.
What is it that you can tell us about pain through your research that you think that osteopaths should know? Like, what is something that you've kind of learned over the last 10 years of research into pain?
I mean, that's the reason I wrote the book. is I wanted osteopaths to. I mean, I think it's taught fairly well now in the I mean, I've got no idea, to be honest, but I get the impression that pain mechanisms are taught now in osteopath colleges. I mean, tell me if I'm wrong. I don't know. But it's just that treatment of chronic pain is multidisciplinary. And when I mean multidisciplinary, I don't mean they go see a physio, they go see an osteopath, they go see a psychologist, whatever. But it's a team that works together and have regular meetings about each patient, and that's probably the most important thing. That if you want to be into chronic pain, you have to be working with other people and collaboratively, not independently in your own little silo.
And I guess, I mean, you wrote the book to try to educate osteopaths about pain mechanisms.
Well, I mean, they should already know that, but it's just how to integrate the knowledge you've learned from pain mechanisms and apply it by working with other people who might know more about pain that's being driven from the brain down than you do.
Right. So how would a private practice osteopath, I guess, be able to? I mean, let's say they're seeing a patient. The patient is a chronic pain patient. You know, you don't have a team of people available to you. What's the best thing? You have a network, but you know, to try and kind of like, it's not like you're going to be able to sit down and have a meeting on a weekly basis with a bunch of people. What is it that somebody can do? What is it that an osteopath can do to make their chances, to give them a better chance of helping this patient to take a more collaborative approach? What are some tips that you can give people?
Well, I mean, it is the networking. I mean, you have to. I mean, so for example, I referred someone to a psychologist a couple of weeks ago. I emailed the psychologist, ask how they're getting on, and they might send me. And so it's not a set meeting every week or so, but it's you're in regular contact to ask how the patient is going, and if there's anything else that you can do in the meantime that will help the patient, sort of thing. So it's a little bit dilute, and not the best scenario, but that's all we've got, I think, in that instance.
Okay. What were the pain mechanisms that you were taught back in your university days, Phil? And have they changed a lot?
We weren't taught them.
Right. So so in terms of understanding how, I guess, maybe let's talk about facilitation and segmental kind of stuff, but also how things kind of change chronically over time and then how they feed back up into the brain. Do you think that were you not taught, or were you not shown, or was that a concept that wasn't?
So when I was a teacher at European school,
right,
I worked quite closely and still do with a guy called Christian Fossum, who's quite a well-known osteopath, and he had a book, and he knew I liked dabbling in mechanisms anyway, and he's like, I think you might be interested in this, and it was a book. It was one of the first publications relating to central sensitization with Clifford Wolf and all of those guys, and I was hooked. For me, it made so much sense. I mean, the whole reason I started that Pain Masters, I was so frustrated with people coming in with apparently identical symptoms, and one person gets better and the other person doesn't. And I just felt like we're missing something so big that I want to know what it is. And that's why that book was the start of the journey, basically.
Yeah. Okay. And I guess then, how has that helped you evolve into a practitioner at the Greenwich side of things that looks into chronic pain with the palliative patient? Like, tell us about that process and how you got into that, and then how you've kind of like evolved your practice to be able to deal with that in that scenario.
So you're talking about palliative care? Yeah,
that's right.
Yeah, I mean, I'm not directly involved with care of patients in palliative care.
Right.
I'm there doing studies. Okay. So I'll go into a ward with a patient, and I'll spend an hour and a half with them doing virtual reality randomized crossover trials.
Okay.
So that's my role. I'm not there to help them as a practitioner.
What have you learned from that, though? What's the
oh my god?
What's the takeaway? What's the takeaway
from the palliative care space?
Yeah, like how do we integrate
life is short? Don't blow it.
Right.
is the biggest takeaway. And to be honest, when I first started, I wasn't looking forward to working with people who were end of life. Um, but I, but from the get go, I found it really empowering. I found talking to these people so inspiring. So once we'd finished the study, I'd sit and chat with them for about an hour,
Yeah.
and they would tell me everything about their lives, and they would ask me about my life, and they were at peace. They'd made peace, most of them, and it was inspiration. It still is.
Yeah. Yeah.
Yeah.
Right. Okay. I want to move on to a line of questioning now and a discussion. I shouldn't really call it questioning, but it's a
Mhm.
line of discussion that really I want to go into the osteopathic side of things and your views on it and
Mhm.
how we can kind of I guess learn from each other.
Mhm.
Before I go into that, I've asked a couple of osteopaths this question, so I'm going to ask you the same question. To you, Phil, what is osteopathy?
Um, it's a manual therapy that's based on a set of principles that are very similar to others that were developed in the same era. Um, I think it's very hard for me to describe what osteopathy is because I've never really had a finger on what osteopathy really is. Um, it's a set of great techniques if used properly. It helps people in the short term really well. Um, our hands-on approach, our palpatory sort of expertise, if you like, for the most part, is for the patient at the very least reassuring for them. How effective it is as a technique that we think it's going to be effective for, I'm still I will never know. But I'm still here after nearly 30 years, still practicing osteopathy. Even though I get frustrated with the profession at times, I still really enjoy what I do, and I keep it stupid simple. And
Right.
yeah,
So you mentioned in there that you feel that the principles were very similar to
so
other.
sort of chiro and
Right.
naturopaths, and I just think that
Well,
they
I
were
think
well.
the guy that put chiropractic together was an osteopathic student.
Yeah,
So,
that's true. But I
yeah.
mean, does it matter if what he
Um,
was?
well, it doesn't matter, but it's an influence, right? It's
Yeah,
like
it's definitely an influence.
you had
Um,
mentors, and
yeah,
they shape how you
yeah,
treat and how you think, and
yeah,
you got to pay credit where credit's due, I guess.
yeah. That's fair enough. Yeah, but I mean, I just think that our strive to be recognised has probably not helped us, and that's why I thought Sweden was a decent
Mm,
gig because we were just left to get on with it,
mm,
and that's what was like in the UK before it was regulated in England. I think the osteopath profession was far happier and freer in those days, where
mm,
they didn't have to prove anything to anybody, and their anecdotal, people like going to see osteopaths because
mm.
they were good at what they do. I mean, you could question, morally whether a patient going back regularly is just is another question, but that's the contract between the osteopath and the patient, I guess, and how
Yeah, I mean,
it's yeah,
people drive up that McDonald's drive-through every other day,
yeah,
and
exactly, yeah.
no one bats an eyelid. So, right. And also you mentioned that osteopathy. You mentioned the hands-on type of
Hmm.
approach and how good that is, and you said that also the techniques that are afforded to osteopaths. Do you think osteopathy is more of a philosophy than it is an actual technique? Do you think that it allows you to have various techniques at your disposal, but is it more of a thought process and how you think rather than how you actually perform?
Well, I think you've got to have the thought process to perform the technique, because if you don't have the thought process, what you're doing.
Mm,
So you've got to have something behind what you're doing. I think my thought processes, they've obviously changed with the work I've done. How am I mean, so for example, if I'm mobilizing a shoulder, I'm not just thinking about the anatomy and the physiology of the shoulder, but I'm also thinking about why their shoulder is tense, and is it due to stress? And if I think it's due to stress and I ask them about stress, then I start talking to them about ways, strategies, how they can help themselves sleep and stress and work and family life and all that. Well, I mean, I'm not going to advise on family life specifically, but strategies to help themselves while I'm
Right.
doing them. So yeah, it's a multidisciplinary thought process, I suppose.
Yeah, yeah, definitely. All right. And you said that the osteopathic profession has kind of been a bit hamstrung by its need for recognition. Um, and do you feel that we could be better served by not really having those constrictions, that we can kind of practice the way we want to practice
I
and
think it's
really
too late. I mean, it's too late for that. We
Mm.
can't go back.
No, I don't think we can go back either. Yeah. And so,
Um,
in that context, then, how do we move forward in terms of being able to continue practicing osteopathy? Because I think osteopathy has also the ability to progress and evolve and come up with new ideas. Um, and I guess maybe not new ideas, but new applications, put it that way.
yeah, yeah.
Um,
I
how do
mean,
we,
Heath is a good example with his strength and conditioning work.
with occupational health and safety too, with
Yeah,
his occupational
absolutely.
health work?
And I used to do some of those for him as well.
Mm,
And I think those. I mean, in some ways, osteopathy is the adjunct to the strength and conditioning in some ways, because they can do that. They can do that every day. Yet they only see us once whenever.
mm.
So you've got to ask yourself. You've got to ask yourself a sort of awkward question, don't you? I mean, what's helping what, and what are we doing, and what are
Yeah,
we doing?
well, I mean, the idea is that if you're following the principles of osteopathy in terms of
Mm.
self-regulation
Yeah.
and healing, the idea
Mhm.
is that you're providing an environment where the body can regulate really well, and then you're giving the capacity for the patient to increase their resilience through the strength and conditioning. And if they
Yeah.
do that, they should be a lot harder to hurt.
Yeah. I would
And then
agree with that.
the theory is that they need to see you less, and that's great.
That's the whole premise of. I mean, my message to patients is, if you do your strategies and your exercise and stuff, you pay for your holiday. If you don't, you pay for my holiday. Simple as that.
Yeah, yeah, right. Do you feel that osteopaths are somewhat, I guess, and maybe not all osteopaths, but I guess osteopaths have a unique ability to identify, I guess, mechanical issues or patterns or strains
I
that,
certainly think they can find mechanical restrictions, but how
yeah,
relevant that is to their presentation would be questionable,
right.
or
And
could be questionable.
so how would you measure that? How would you measure the relevance to the presentation?
I don't think you can. I mean, so if someone comes in with let's say a disc bulge or symptoms of a disc bulge, and their low back is hypermobile,
Mm.
but their mid back is stiff as buggery. How do you set out your stall then? So what you find is not really directly related to their disc problem.
Right. Yeah, I get that. I get that bit. I
Mhm.
mean, but I'm more talking about a particular kind of pattern of mechanics. Right? I get stiffness in the thoracics, but
Mhm.
they're more general, I
Yeah.
guess, general things. But in terms of things like, short legs,
Uh, yeah, I mean, I
different.
don't pay much. I don't pay much heed to short legs or scoliosis or kyphoses unless they're
Mm,
so far off the chart
mm,
that there's something needs to be done. And I'm only saying that because of you know a lot of experience. Because I mean, I worked with British Gymnastics for quite a few years,
mm,
and they'd had leg breaks. And one of the guys I remember, he had a 25 mil leg length difference, and he was competing
mm,
for Great Britain on the trampoline, and he didn't have any pain. I mean, he might do later on, but
mm.
it didn't stop him doing anything. And the severity of the deformity or the mechanical sort of restriction doesn't have any bearing whatsoever on the severity of pain.
Right. And so, but you don't think that mechanical restriction, given enough time, can present itself as a painful response at a
Well, I
certain
think it
level of
can,
tissue?
but I think there'll be a lot more other stuff going on. So I would never look at one thing and say, oh, if I fix that, then he's going to be all right.
Oh no, I wasn't. That's not where I was going with that. I was more saying that given enough time, does a certain
Mhm.
mechanical restriction, given enough time to play itself out, could that potentially cause enough load on tissue that would
Oh, for sure.
present as
For
a
sure.
right?
Yeah, for sure.
And
Sorry,
so
I misunderstood you.
so the question then comes back: do you think osteopaths are any good at identifying those mechanical patterns or restrictions?
Yeah,
And
of course, yeah.
right.
Yeah.
Um, okay. And do you think that we're also uniquely placed to, given the principles of osteopathy, do you think that we're uniquely positioned to help with chronic pain?
Individually, no.
Right. Um, okay. Can you expand on that a little bit? I mean, individually, no, but
Because uh, we're, t- we're manual therapists. We apply manual techniques of,
Mhm.
you know, you never know what you're going to get when you go to an osteopath, because we're so diverse in how we apply these techniques. But there are so many other facets related to chronic pain that are not in our area of expertise that I don't think we're unique.
Well, okay, so maybe I should rephrase that. Rather than osteopaths being uniquely positioned, do you think osteopathy is uniquely positioned as a medicine, as a system of
Um,
medicine, given
for
its
chronic
philosophy?
pain,
Well, given its philosophy and its principles, do you think? I mean, look, if you look at osteopathy in the United States, they've got hospitals set up, just osteopathic hospitals with
yeah, but
with
they're doing all sorts of other stuff. They're doing
they
surgery.
are.
They're prescribing medicines. They're doing all sorts of stuff.
Yeah, and that's the thing. Osteopathy itself is a system of medicine. It's not just a combination of different techniques. I
But
mean,
I would argue that not many osteopaths in the States actually practice manual therapy. They
that
practice as
true,
medics. Yeah.
true, yeah. And there could be some
So it's not
osteopaths.
unique in that sense.
Yeah, there could be some osteopaths there practicing manual therapy. There could be some ones that don't. There could be other people. There could be psychologists. There could be naturopaths there. What I'm saying is that is osteopathy as a philosophy, as a structure, as a system of medicine. Do you think that has a place in, I guess, helping with chronic pain? Is it uniquely positioned, given our integration of body, mind, spirit, given our understanding of regulation? You,
I
you
don't.
don't you don't
No.
think that
We
it
may
has
be thinking about mind and body, but we don't apply it. We don't apply mind and body.
okay. Is that a problem for the osteopath or the problem for osteopathy? Like, is that a practitioner
I would
problem?
think it's. I would think it'd be. I think you can't separate them.
Right. Okay. Um, right. Okay. I would probably disagree with that. I think
That's
the
fine.
yeah.
I'm happy to continue the discussion.
Yeah, I think it's. I mean, sometimes I fall short personally of applying osteopathy in the best way that I can. I don't blame osteopathy. I can tend to look at
Oh, I
myself and
don't
say, well,
blame
what?
osteopathy. I just think we're not. We're one. We've got one construct, and that's what we do with our hands.
Oh, geez, there'll be a lot of people out there that'll argue with you,
I
Phil.
know they will. I know they will. But at
You
the end of
know,
the day,
there's a
when
lot
they
of
leave
people
your
that.
office, I mean, we do give them advice as well. But if you want to go back to the principle of osteopathy, it doesn't include help and strategies, really.
Well, I mean, if you look at the body, mind, and spirit, I mean, the spirit itself is more to do with social well-being, more to do with psychosocial
But how
issues.
do we help them do that? How do we help them in that sphere?
Well, I guess how you help them is you go out and you learn how to help them. You might do another psychology degree and
But
apply
is that
it.
osteopathy?
Well, the thought process is osteopathy. I mean, the reason why I've done it in the first place is he can help them in that fashion. It's like our old mate Heath when I did his strength and conditioning stuff, right? I mean,
Yeah.
that's not in osteopathic education
No.
formally,
No.
but he's
No.
gone out and said, "Look, I need to have this I need to have this tool in my
Absolutely.
toolbox, and I've got to go out and do it." And so, and this is the point I'm trying to make: is that the system itself allows you to go out and learn different things, and then come back and integrate it in the multidisciplinary fashion. That would be almost like a super practitioner that we're talking about. But and there's nothing wrong with kind of having that ambition,
No,
um,
not at all. But I would
right?
just question
And
whether it's osteopathy or not.
well, I agree with you
In
in
its
that.
classical sense, in its original sense.
Yeah, in its classical sense, osteopathy has been mainly known as a hands-on
Yeah.
profession. But I think as the times have evolved, there's been applications that are nutritional that have been. I know
Absolutely.
that I've spoken to a couple of osteopaths on the podcast who get into neuro-emotional technique and
Mhm.
looking at psychological
Yeah,
I guess techniques and talking to their patients.
which is
Um,
great.
yeah, that's right.
It's
But
fantastic.
all of them tell me that they still apply osteopathy in the way that they think. They just use the different tools that they've learned. Um, and so, is that osteopathy? You're saying it's not. You're saying it's something else brought in.
Well, I'm just going back to the original principles. For me, it's
The principles don't mention
for
anything
me,
about hands-on therapy.
we're evolving into a biopsychosocial therapist.
Hmm.
Now,
Well, isn't
there'll be
mind
lots of
body mind?
arguments before and against that being classed as
Yeah,
osteopathy or not.
isn't body, mind, and spirit biopsychosocial? Isn't that, if you break that down, body, mind, spirit, biopsychosocial?
Sort of, I think, but
It's
um,
almost a synonym for it.
yeah.
Hello, everyone. Just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes. So, for more information, please see the show notes. Now, enjoy and back to the show.
The spiritual stuff is something different, and I guess you would equate that to the social, but I would argue that spiritual and social, even though they're intertwined, they're separate constructs.
Yeah, right. I guess, I mean, that's a debate to be had, and
Yeah, absolutely. I mean,
but
definitely the other
there's,
thing that I've been doing in the palliative care space is looking at the effects of spiritual interventions for
right.
pain and symptoms, anxiety and dignity and all that sort of stuff. And it generally is, but people who work in those areas are specialists at their job. I mean, it's a separate entity.
That's
Um,
yeah,
and spirituality doesn't necessarily mean religion. It means some form of existentialism that the patient may relate to. They might love being in the mountains, and they have an attraction spiritually towards the mountains or water or hanging out with other people or going down the local boozer and having a few beers with their mates or whatever. That might be their spiritual sort of enlightenment for the week, sort of thing.
yeah,
And so for that for me, I guess thinking about it now is something I do a lot within practices, is try to find, and that's going back to this whole meaning and purpose, is find a way that they can reflect on their lives
right.
to relate to what gives them meaning. And I think if you can get that,
Do you think
you're on
that
the way,
gives them?
you're
Do you
on the
think
way
that?
to helping them.
Do you think that? Yeah. Sorry,
Yeah,
go
go on,
ahead.
sorry.
No, continue your thought process.
I just think that people who have no meaning are never going to get better, or
I
they're
agree.
not going to try to get better, because what's the
Yeah,
point?
I agree with you totally. And so you're talking about obviously having a spiritual impact through finding meaning and purpose.
Mm-hmm.
And you're an osteopath, Phil. You've gone down that.
I don't think of it as an osteopathic thought process. I think it's something I've picked up from pastoral care in a palliative care unit.
Mm. But it's made sense to you as an osteopath.
It's made sense to me.
Yeah. It's not
Yeah.
antithetical to the way that you think.
Yeah.
And you think like an osteopath.
Do I?
Well, you're an osteopath. I mean,
I know I'm an
you've been influenced by osteopaths, to think you're
absolutely, and I'm still an osteopath,
yeah,
and I still treat from a musculoskeletal perspective. I still treat as an osteopath, but the stuff I bring in from either side, I don't really think I don't think it comes through my osteopathic head.
right. Are you bringing in? Do you think you bring in? Are you bringing in tools and techniques, or are you bringing in actual I guess, strategies, philosophy?
Just strategies, yeah. Or not even that. I mean, just a key word that will trigger something in them.
Mm.
You know,
And
even it could be
what's your
something
aim?
stupid simple like put your pillow there and not there, and then you get a better night's rest and you wake up more refreshed and you're less tense and you have less pain.
Yeah.
Something like that. Or it could be, why do people like you? Why do your friends like you?
Mm.
And then that's the sort of thing they grab a hold of that they have gratitude for.
Yeah.
Yeah, so there's lots of different. I mean, I can't. I mean, those are examples, and there's so many different types of example.
Yeah.
But I don't class that as me being osteopathic. Really,
Right.
it's me being self-reflective, uh, hopefully well read, and a drive to learn more and integrate what I think is sort of necessary to get. Like, I've just started an acceptance and commitment therapy course to learn how to apply that stuff.
Mm.
Because again, acceptance is a big part of people getting better. If they can't accept that their pain or the severity of their pain or the duration of their pain, then they're going to keep fighting it all the time. And the more you fight it, the more tense you get, and the more fatigued you get, the less sleep you get. It's so you've got to sort of break that cycle.
Yeah, I'm at a loss to see how your I guess your quest for expanding your toolbox and helping your patients is not considered osteopathy, or you wouldn't consider osteopathy. I'm hearing what you're saying, and I just see
I'm
that
all
as
I try to be a little bit of everything, I suppose, and then
yeah,
recognize where I'm limited, and then refer on.
yeah, right, okay.
Yeah.
And I guess where you feel you are limited, but you think that you can have an impact, is that where you go off and do extra study?
Yeah, to a point. I
Yeah.
mean, the other thing is, I'm only like 5 years off finishing, and I'm looking to wind down now. To be honest, I want to enjoy my life. I mean,
Finishing as an osteopath?
well, I'm just retiring. Yeah, yeah,
Yeah, right. And what's the was that been a plan all along?
yeah. I mean, I wouldn't mind doing a couple of days a week. Till I pop my clogs, sort of thing. But
Yeah.
I want to go out and enjoy myself with my kids. I want to do more climbing. I want to go skiing. I want to, and I've got bit of pension stuff going on. So I want to chill out.
Yeah, fair enough. That's you're totally entitled to that.
I'm an old dad, I'm 60 next year, and I've got twins who are 11 and a feisty, and they're all feisty and defiant.
Are what do you got? Twin girls or twin boys?
One of each, and I've got an older
What?
girl, and I've got a very older boy in England.
Yeah, right. Well, they'll keep you busy, mate, and they'll keep you on your
Yeah,
toes, and you got to stay
and they're
fit. You've
and they're
also
more
finished.
important to me now
Hmm.
than my work. To be fair,
Yeah,
I
definitely.
want to hang
That's
out with
totally.
them. They're
Yeah.
getting to the age where I want to sort of be part of I want to influence them
Yeah,
in
right.
a positive way.
Yeah, okay. All right. Well, I guess the next thing I want to ask you, before we kind of wrap up, is tell us about osteopathy now, like the way you're seeing things happen. I mean, we're both practicing in Sydney and we're in Australia. Tell us how you see osteopathy, particularly in New South Wales and Australia, right now. Where is it positioned, and what do you think? What do you think we can do better moving forward into the future?
I think it's a really difficult question. I think we've got to be more involved, and I know the Osteopathy Australia are sort of striving to get the research stuff going
Hmm.
with the funding and what have you. Um, but the difficulty is osteopaths, I don't think are that interested. They're interested in being in their clinic and having their hands on, and they love it.
Hmm.
Um, I guess. I mean, in my research circles, we have all of these different research groups, and these young kids are coming through, are so motivated to get their name on the research map,
Hmm.
and they'll do everything for nothing to get on that step of the ladder. And I think that's the way this profession has to act, to encourage people to be more inquisitive about what we do and why we do it, and how we can enhance the profession
Hmm.
from an evidence-based perspective, because that's, after all, why we went for recognition. Is we wanted to be validated. But the trouble is, if you want to be validated, you have to be evidence-based.
By who? Who do you?
I mean, I do think evidence, but it's not the be all and end all, and there's arguments a lot for and a lot against. But if you put yourself in that position, you have to go forwards. And
So
as I said before, it's too late to go backwards, so we have to go forwards.
No, I agree. I don't think we can go backwards. I think we do need to go forward. Who do you think we're looking for validation from?
Well, health insurance companies, Medicare, anything that makes what we do more accessible.
Right. Okay. And do you think we don't have a level of access now that's satisfactory?
We don't get as much as chiropractics.
As much what? What do you mean?
We don't get as much accessibility through different health insurance companies. They have more. There's more access to chiro than there is osteopathy.
Do you think that's a research problem or a numbers problem? Like, I mean, chiropractors.
I think it's a numbers, and it's. I mean, but they're pretty good. They're pretty good on the research as well, to be honest. I mean, I'm not saying what they churn out is great, but they're churning it out nonetheless.
No, what I mean by numbers is that the chiropractors generally see
I know what
a
you
lot
meant.
more volume of patients, right?
Yeah.
And that obviously speaks volumes to the health insurance companies.
Yeah.
Because when they have a demand, when there's people that are paying their premium saying, I want to see the chiropractor, well, the insurance company will go, great, that's something we could offer. And so, do you think that's a research issue or
no, I don't think it's just a research issue, but the chiros have done their research along the way to get them into that position, and they've got the numbers they've got much more in the profession than we have as well.
Yeah.
Which help. Yeah. I think it's a bit of everything, and their business, they're much more business savvy, I think, on the whole than we are as well. They're much more driven by the business model than we are.
Right.
I think there's two types of practitioner. There's the value for money healthcare, that cost-effective healthcare or business. And I think you go down one route or the other.
Yeah, I spoke to an osteopath a couple of weeks ago who said that osteopaths have a major problem with their relationship with money. They feel
I think absolutely right.
Yeah.
Correct.
Yeah, they feel like that if they're making money, that they somehow stealing it off their patients.
Yeah.
And that's something that I think needs to change.
Yeah, to a point, but I think it's healthy at the same time. That
the self-reflection is healthy. I think that's what you mean, right? Like the reflection on what the value that you're giving somebody, that's definitely healthy. But at the end of the day, if you're charging for what you're giving out, you shouldn't really feel bad about that. There's a problem.
I mean, I don't feel bad. I mean, but I don't charge. I mean,
you charge for accessibility, right? Like you still need to give people enough.
I want people to be able to afford to come and see me.
Yeah.
And because there's an osteopath up the road here who charges, I don't know, a couple $100 a session, and I'm charging a bit less than that. But in reality, with my qualifications and the experience I've got, it should be the other way around. But that's not me. I want to help people.
Yeah, right. So outside of I guess research and what you said in terms of having that passion to go out and be more inquisitive, where do you think the profession can really do better at, or what do you think?
I think they're trying really hard at the moment. I couldn't criticise them for.
No, it's not so much criticism.
Forward. I mean, Anthony's done an amazing job with Osteopathy Australia. He's really driven forwards.
Yeah, less much about Osteopathy Australia. I'm talking about us as a profession, as osteopaths. How we practice and how we view things and our outlook on things. That's what I'm talking about. I'm not just talking about.
I know, but he's making and moving a lot of things, as is the profession at that level, to get us to recognise and they open our eyes to different CPD courses, for example, that might not be classical osteopathy type courses. So they're opening the gateways for us to open our eyes, I suppose.
Yeah.
And without that, because osteopaths are a sort of bunch of people who like just to get on with their job. They don't really speak to other osteopaths as a rule. There's no peer group sort of mentality here, is there really?
Do you think that's where we could be doing better?
That's one thing I would think that we would benefit from, is to have, like when I lived in New Zealand, we had to do peer group sessions every month. We we had to meet every month.
Yeah.
And report back to MNZRO.
Well, I think just face-to-face social contact is, like just having a beer with your colleague.
Oh, I'd love to. I'd love to do it.
Yeah.
I mean, I do it with Matt Fry every now and again.
Mm.
And there used to be a bunch of pommy osteos in Sydney. They used to meet every now and again.
Yeah.
But that doesn't happen so much anymore.
Yeah. Well, we'll see if we can speak to our mate Kevin Finnan, who's looking after that New South Wales Osteopathy Facebook group. Maybe
people like Headley Chin and Alison Lim, and I mean, they're great socially. Fantastic.
They are. Alison's fantastic. Yeah. No, they're great. They're great to have a drink with. And so we'll speak and see if we can organise something. I think that's a fantastic idea.
I mean, just meeting once every couple of months for a meal and a beer.
Yeah, and just talking about how poorly Newcastle's doing in the Premier League it'll be always good, and how.
Welcome to my life.
With all that money, we thought that Saudi, the injection of money would just, you guys would move into the top 4. But
we did, but then we moved out of it again.
Where do you think the problems are going on, mate? What's going on there at Newcastle?
Oh no, they've been restricted by all of these Premier League
rules.
Rules, yeah.
Yeah, right. Except Man City. Man City got all the rules go their way, but Newcastle United.
I think they're gonna come unstuck.
Yeah, right.
They have to.
Yeah, well, who knows? You don't know where this. I think a lot of this stuff just happens behind closed doors.
Of course.
Yeah, and the thing is, a lot of these players, they drive a lot of the money for UEFA and for FIFA, and you go and break a club like that with your big names, all of a sudden,
but FIFA and UEFA have no influence on the Premier League.
No, but they're big money spinners for the Premier League too, I guess.
Yeah.
Anyway, that's
a real shame. I mean, I was really looking forward. If you speak to most people in Newcastle, they don't give a stuff about human rights and stuff in Saudi Arabia. They just want to see their team do well. And it's a terrible thing to say, but they don't care about anything else.
Was that a problem for you when they took over? When the Saudis kind of?
Oh, I mean, I was. One side, the devil in me was like, fantastic, we're going to have a good team, and we're going to sort of, we've got a passionate supporter base. It's the most amazing stadium, loudest stadium you'll ever go in, and but the other side of me is like, oh, it doesn't sit well,
Yeah, it's But
they've been real geniuses. They've gone in and they've gone into grassroots. They've pumped money into all of the junior football, the local clubs, the bars, the hotels. They've been really clever.
I think that you need to obviously know what things you can control and things that you can't.
Exactly.
Chelsea had a Russian oligarch as an owner for a long time.
Yeah.
Man City have a Qatari conglomerate, and who knows what they're up to. And so there are things that are out of your control as a fan. There are things that are in your control as a fan.
I mean, if Newcastle get beat, my weekend's shite. If they win, my weekend's fantastic. It's a visceral thing. No one understands why I get angry.
I get you. I get you. I understand.
I get really upset when Newcastle get beat.
Yeah, right. So you're not happy.
The kids don't come anywhere near me. My wife's like, "Got beat, don't go near him."
Mate, on that note, I guess I'll end the conversation, but I want to thank you for taking the time tonight. And what we'll do, we'll speak to Kevin and Alison and see if we can organise a little catch up over a beer sometime in the new year. I know it's a busy time for everyone now. And we'll hopefully do it when the sun's still out and the Sydney summer is blazing. But Phil, thank you for your time tonight. Everybody else, big shout out. Thank you to Phil. A shout out to Heath Williams for helping us set this up as well. Stay along with me, Phil, and for everybody else, have a good evening, and I'll catch you on the next episode.